clinicians. I'm back with Dr. Michael Lewis, Director of Foundation Endodontics at Teaneck, New Jersey. This is the second part of a presentation by Dr. Lewis titled Maxillary Sinusitis of Endodontic Origin. If you haven't seen the first part, please make sure to go back and take a look at that before we view the second part. Michael, again, thanks so much for joining me.
Thank you for having me, Alan.
It's wonderful to have you. So, Michael, why don't you go ahead and talk about the second case here with of a tooth with endodontic infection with maxillary sinus implications.
So here, this is the second case that presented to me. Patients referred for root canal treatment of tooth number 2 and tooth number 3. Patient had recently had some crown preps done on these two teeth and had complained to their dentist of painful response to cold. As patient came in, we confirmed that the teeth were in fact very inflamed, and as a result of the recent crown preparations, and the patient exhibited a lingering painful response to cold, indicating an irreversible pulpitis. These teeth were still vital, and here we completed the case. Here you can see the post-operative image to the right. Both teeth completed single visit endodontics. Looking ahead at the internal canal anatomy of these teeth, we can actually see the images associated with each tooth. Here you can actually see the MB2 canal completely located and debrided. It takes the form of two separate canals that merge in the apical third. And on the image to the right, we see more of an anastomosis of those two canals, where they form in more of an ovoid shaped canal, two different types of common anatomy that we see all the time. Again, the point of highlighting this is that the MB2 is common, it is present, and does need to be cleaned out. And moving forward to the next slide, we can actually see the preoperative and postoperative cone beam CT images. Now, unlike the first patient, this patient reported very little in the way of sinus symptoms, not much of a response on the preoperative snot survey. But here nevertheless, we see, despite the vital tissue inside these canals, and despite the lack of an osseous lesion associated with this teeth, we actually can see sinus thickening associated with these two teeth. And when you look at the 30-day postoperative scan, you can actually see complete resolution of that maxillary sinusitis. That because there was no sinus symptoms, we did not take a snot survey. She had taken it and it was negative. But it really illustrates a very interesting point, which is that you don't actually have to have canal necrosis in order to have radiographic symptoms. And that's something that I don't think is really truly appreciated within the broader medical community, because oftentimes if a patient goes to an ENT and they present with sinus problems, as you saw in that previous case, there's no clear osseous lesion pointing the way to pathology. And that's a really important point to appreciate, that you don't even have to have canal necrosis to see sinus thickening. You just have to have inflammation that's spread to those tissues. And an ENT looking at this, if the patient had presented with chronic sinus symptoms, or it had developed into chronic sinus symptoms, there's very little to see in the CT scan that can clearly show that it is dental in origin, and it's something that we need to be aware of.
And Michael, the source of a situation in which an irreversible pulpitis could lead to sinusitis of this type, or at least maybe a subclinical level of thickening of the sinus membrane, would probably follow the same mechanism as in some cases where you have irreversible pulpitis. You would end up having some early signs of bone loss at the periapex.
Well, in this case, because the sinuses are so intimately associated with the mesial buccal root is so intimately associated with the sinus floor, it's hard to appreciate an osseous lesion from the CT scan. I'm sure it's there, but it's too small and subtle to see, because the layer of bone there is so thin. It's hard to appreciate from a radiographic standpoint.
But in terms of the mechanism of the sinusitis, when you have a vital pulp, then it's probably the same thing, because sometimes you get a inflammatory response apically that is not yet infected when you have inflammation in the pulp. So you would probably.
It was the exact same mechanism, absolutely.
At least we can hypothesize that's what's going on. So terrific. That's interesting. So it's possible for, you know, irreversible pulpitis. And also, it's also important to realize that when you have irreversible pulpitis in a multi-rooted tooth, it's possible that one of the roots might be in a more advanced level of inflammation than the other one. So the response may not necessarily always be 100% accurate. So you could have more bacterial infection in one root than the other that could potentially cause to these types of additional symptoms. So let's move on to the next case, Michael. What's this one?
Okay, so this was a case, again, very little preoperative sinus symptoms, yet despite that we see radiographic evidence of the maxillary sinusitis. Here you see the preoperative radiograph. You can see the image to the right has the cone beam CT scan. We can see associated sinus thickening. Here you don't have that clear lobulation that you saw in the previous case, but nevertheless we do see thickening of the walls of the sinus, and it actually spreads up the lateral walls of the sinus, which is not something that you could clearly point to and say it is endodontic in origin. It's certainly not clear from the cone beam CT that it is dental in origin. Nevertheless, when we take a look at the, here's actually the internal images of the tooth. Here we can see what's really interesting about those internal images, Alan. If you look at the image to the left, that is the image after, that's a photograph of after the MB1 was cleared out. And it's, you really can't see a second mesiobuccal canal inside that image, which really drives home the point just how technique sensitive root canal therapy is. It's something that's really not appreciated enough, that this is a really, really technique sensitive procedure. And if you want good results, you got to find that MB2. And here, if you look at the image to the right, you can see the MB2 was located and cleared out underneath that shelf of tertiary dentin. And here you can actually see that canal, the true ovoid shape of that canal is fully revealed after the MB2 canal was located and debrided. Not easy to do. It's something that root canal should not be seen as a commodity. It should not be seen as a just pick up a shirt at Neiman Marcus or I can get it at TJ Maxx. It's the same thing. Right. No, it's not. It's extremely technique sensitive, and the consequences of a case like this, if I had just simply stopped the root canal at the stage of the image to the left, there's no doubt in my mind that that had a good potential for eventually leading up to chronic apical periodontitis, which could then manifest as all the symptoms seen in the SNOT survey: reduced sleep, fatigue, irritability, and this is an important and profound impact upon a patient's quality of life. And they should really be aware that root canals are extremely technique sensitive.
Yeah, and that brings up a good point. And I think the art of the MB2, if you want to call it, is finding that right balance where you kind of, you know that it's there most of the time, but then how do you remove just enough dentin so you don't weaken the tooth structure, maximize your chance of finding it, and then know when it's not there so you're not doing it. And in that situation, I think the CBCTs are greatly helpful in terms of finding it out. I think, to be honest though, not every single tooth would require CBCT, but I think if you have a maxillary first molar specifically and you're in there and you can't find an MB2, it will probably not be a bad idea to have a CBCT at that point to just kind of make sure that you haven't missed it, unless you're really sure that you're in that 10% of the population where they might have a completely non-ribbon shaped root. What do you think?
I used to be more circumspect in taking the cone beam CTs. You get about, with a small field of view cone beam CT, you get about 11 microsieverts of radiation. Just to put things in perspective, when you go on a plane flight from New York to Los Angeles, you get 40 microsieverts of radiation. It's not a lot of radiation. Each of our radiographs are a single microsievert if you're using f-speed digital sensors, and it's really not a high amount of radiation. When I compare and when I weigh out the benefits versus the downsides of taking a cone beam CT, on these upper molars where the bone is not so dense and the exposure, the amount of radiation the patient is getting is not that high, I do believe that the benefits of taking a pre-op cone beam CT image outweigh the downsides. I don't want to miss an MB2, especially as I'm becoming more sensitive to the profound implications of missing canal anatomy inside these upper teeth. It's not simply, oh, you know, if it's not working out, the patient will let me know. The patient will probably not let you know. The patient will probably have low-grade issues that don't become apparent for many years out. And I think that there's tremendous value in taking cone beam CT images, oftentimes preoperatively, sometimes postoperatively, that really the benefits to the patient are significant and are warranted to take the cone beam CTs on these upper maxillary molars. On the lower molars,
yeah.
I tend to be more judicious. There's more radiation, but these upper molars, I certainly think it's within the standard of care to take a cone beam CT exposure.
So I agree with you 100% in an ideal world, though. But hasn't the American Society of Endodontists position paper kind of questioned the use of the CBCT in all these cases?
So they leave it up to the discretion of the practitioner in many cases. If you're concerned about additional canal anatomy, it's certainly warranted. And if you want to make sure that you didn't miss anything, in a case like this, here we had, you know, I wasn't sure if there was an MB3. It certainly made sense to me to take another exposure.
Okay, so let's move on here to your preoperative and postoperative CTs showing the sinus.
So here we see, again, resolution of that maxillary sinusitis. And oftentimes, you know, the resolution of that maxillary sinusitis it can serve the same purpose as an epilus can serve in terms of being a prognostic indicator. We know that we're successful in eradicating the infection if the epilus goes away in an asymptomatic apical abscess. And one of the really tough things about endodontics is that oftentimes we don't know whether we're successful for 18 months. And what I've found is that when you see resolution of that maxillary sinusitis, it can serve as a tremendous prognostic indicator and give you confidence if the tooth is serving as a terminal abutment to a long span bridge, and you don't want to move forward until you're absolutely sure that everything's good. Oftentimes, the resolution of that maxillary sinusitis can serve the same function as resolution of an epilus, an asymptomatic apical abscess. So there is utility in documenting the resolution of that maxillary sinusitis.
Yeah.
Here we see, in this case, the patient took a preoperative snot survey and really didn't have much in the way of symptoms, which is not unusual in cases like this where you see radiographic sinusitis, but you don't see much in the way of symptoms. And when she came back for her 30-day follow-up, we see here that the sinus pressure is significantly less, but from a quantitative standpoint, her symptoms did not really improve all that much. Again, it's not something that you're going to see as dramatically as you did in the first case, but you will see some cases like this where they're subclinical or the symptoms are totally absent and the patient won't really appreciate the benefit. But there's no doubt in my mind, had this situation been left unchecked, it would progress and develop into a more significant symptoms. More
chronic issue for the patient. You're absolutely right. So all of this brings up some important questions here. Yeah, a couple of great cases that you shared with us. But let me recap so far everything that we've been kind of talking about in terms of a question. First, how common is maxillary sinusitis of dental origin?
You know, it's a great question. Maxillary sinusitis was initially thought to comprise 10 to 12% of all cases of maxillary sinusitis. When you look at the categories of maxillary sinusitis, it's really divided into three categories. Two categories. There's sinusitis of dental origin and sinusitis of non-dental origin. And within the umbrella of the dental origin category, there's sinusitis of periodontal origin, there's sinusitis of endodontic origin, and then there's sinusitis of iatrogenic origin, where perhaps some foreign bodies were pushed through the root apex and into the sinus, or it could be some sealer that's not very biocompatible, causing a persistent irritation to the sinus. And then you also have cases where a tooth was extracted and you get a persistent oral antral fistula that develops, and that oral antral fistula allows for the passageway of bacteria into the sinus, which cause persistent issues. You know, the question of how common is maxillary sinusitis of endodontic origin, I don't think we have real great data on how frequent that particular etiology is within the subcategory of dental origin. But a study by Ferguson indicated that roughly 30 to 40% of all overall maxillary sinusitis is actually of dental origin. If the sinusitis is localized to one sinus and the other sinus is clear, the incidence climbs up to 70%. That's in a study by Matsumoto. And if it is unilateral and it occludes the sinus completely, the implication that it's dental in origin climbs to 86%, which is a study by Bamelli. And these are all really relevant statistics, because if an ENT is confronted with a CT scan and the CT scan shows maxillary sinusitis, unilateral maxillary sinusitis, the first thought should be, is this dental in origin? And I really do believe that a referral to a cone beam CT equipped endodontic specialist would really be warranted, because oftentimes these types of cases really are very technique sensitive, as I illustrated before, and it does require the expertise of a specialist in order to diagnose and treat it. There was one great study by Ferguson which showed that in many cases of maxillary sinusitis, the patient was sent back to the general dentist who the patient was under their care and asked, hey, does this patient have a dental infection? And in over 18 out of 19 patients where the patient was cleared and sent back to the ENT and said, no, this is not dental in origin. And that's fairly typical. And there's lots of reasons why that could be. Why are general dentists kind of missing this diagnosis? Number one, there's a lack of appreciation for how these types of cases will present, in the sense that they'll often be subclinical and their symptoms won't be very acute. Oftentimes, go ahead.
No, I was going to say that's a very interesting study. I wasn't aware of that, and that actually shows the need for further education, specifically in the area of diagnostics. I think that's what's been missing, and that might be something that is that should be a priority. Oftentimes we focus on the carpentry aspects of dentistry, which is purely the mechanical parts of it, but these underlying biological principles of proper diagnosis is the primary step required to implement the correct treatment plan that will maximize the rate of success. I think the focus has been put on the wrong aspect of care a little bit too much in the past. But let me also ask you, Michael, about the patients themselves. Are they oftentimes, could they not be aware of some of these connections and how that can sinusitis go subclinically or of a dental origin?
Yeah, as is the case with my wife, there can be long periods of quiescence where the patient really isn't symptomatic. And that's really more the rule than the exception. Most of my patients who come in with clear evidence of maxillary sinusitis are oftentimes asymptomatic or only mildly symptomatic. And it's the job of a clinician, through the use of the SNOT survey, which I'm kind of offering as a tool here, to kind of recognize those cases where it's subclinical, and to often recognize there may be cases which are not, which present with no clinical symptoms, not even subclinical symptoms. And those patients too will present with radiographic evidence of sinusitis that will resolve once proper endodontic therapy is rendered.
Yeah, that does make sense. So what have been some observations that you've had overall in your career and based on your experience of a typical patient with MSDO, maxillary sinusitis of dental origin, and how they present basically?
So I see a lot of patients that come to me, and on my intake form for the history, oftentimes I ask them, have you ever seen an ENT? Do you have any sinus problems? Have you had any medical physicians attribute your sinus problems to causes? And what I've noticed is that a lot of patients who come in, they will report that, yeah, I've seen an ENT, yeah, they've put me on Flonase, or in a couple of exceptional cases, they've been recommended to have surgery done once the Flonase wasn't adequate in addressing their symptoms. And some of them have accepted the surgery, some of them have not. And some of them were put on neti pots, or they have a history of recurrent acute sinus infections that have been treated with antibiotics. And more oftentimes than not, the underlying cause is actually a dental origin. And once we relieve that dental infection, although the complaints will typically resolve. That is my experience, and more work is done in order to quantify and study how and validate what these observations are. But I see it quite frequently, and I think that there's a tremendous need for collaboration between the ENT and the endodontic specialist. You know, oftentimes these patients will have chronic post-nasal drip. And one of the things that I've noticed, Alan, is that when I recline, I'll oftentimes get patients referred to me for tooth number 18, and we'll do a limited examination of the tooth in question, and we'll get started working on the tooth as endopathology, and we'll get started on working on those teeth. And when I lean the patient back in the chair, I think every dentist has had the experience of just having a really difficult patient to treat. Why is it so difficult to treat them? Because they're perpetually swallowing. Every 2 seconds, that mandible is moving up and down because they have to clear, they have to swallow. And the patient will say, oh, I've got to clear the saliva out of my mouth. Well, actually, it's not the saliva, Alan, it's the post-nasal drip. And when I see that, and I see a patient coming in, and I have that rubber dam on, and that mandible is moving up and down every couple of seconds because they're constantly swallowing, well, that's kind of a red flag, Alan. And I say, all right, let's take a look at your upper teeth, because there's a good chance there's endodontic pathology. And that would make for a really good study, because I think it's an underappreciated symptom. Oftentimes, the doctors will say, oh, this is a really difficult patient to work on. Why is it difficult? It's difficult because of their post-nasal drip. And this is not something I've really seen or read a lot about, and it's an observation that I've made. I'd love to have it validated by other clinicians, but there's no doubt in my mind that there's something real there, and that it's something that should be noted upon a patient's chart when that happens. And it is a reason to go in and take a closer look at those upper maxillary teeth, because more oftentimes than not, it is dental in origin.
Yeah, you're absolutely right. I mean, it's a fairly common thing to have a patient with postnasal drip. Now, of course, we're not saying that all postnasal drip is caused by infections of odontogenic origin. Obviously, there are plenty of patients that have chronic sinusitis due to allergies and all kinds of different types of issues, but it's an important area to kind of consider and pay attention to diagnostically and focus your attention, so at least you can rule out teeth as a potential source. I think from what I gather, the problem of maxillary sinusitis of odontogenic origin requires basically raising awareness at 3 different levels. The physician, which would be your PCP, your otolaryngologist, ENT, at the level of the dentist, which would be the general dentist, various specialists in the profession, and even obviously among endodontists, which it actually should be their area of expertise, as well as the patient. So why don't we just discuss how we can do that by specifically addressing each group? And let's probably start first by the physician, the primary care physician, otolaryngologist. What can we do in order to improve our raise the level of awareness in this group?
Okay, so sensitivity testing is probably the easiest and simplest thing. If a patient is presenting with sinus infection and it's presenting on one side, a simple palpation test in the mucobuccal fold adjacent to the roots of the upper maxillary molars and premolars can, if there's an area where, oh, that's more tender, it's probably dental in origin. That's a simple test. A simple percussion test would also be relevant. Again, it's not going to catch all these cases, but it'll catch a large number. And it doesn't have to be very intense or discomfort, but if one area is feeling different than the others, that should be enough to prompt a referral to the patient's dentist or local specialist that the physician has a relationship with. I think that would be a good first step in terms of catching a lot of these cases that might not otherwise be caught. And that's a good first step. That should be, I'm not sure if it's happening as much as I think it should be. And it's something I just want to bring awareness to as a simple screening tool to capture a lot of these endodontic origin maxillary sinusitis cases.
Yeah, because currently, I mean, what is the protocol with a patient that's going in with maxillary sinusitis to a otolaryngologist?
I think there is that recommendation to do that screening. How often that protocol is carried out, I'm not sure, because speaking to a lot of endodontists, speaking to a lot of dentists, the number of referrals that are made from an ENT or primary care physician is not all that high. And there's some reports in the literature that it's oftentimes underappreciated. So that's fairly well documented within the literature that there isn't that referral pattern taking place. So it's something that needs examination and further study.
So it's obvious, given the close anatomic relationship between the teeth and these paranasal sinuses, specifically the maxillary sinuses, that you can have drainage from the roots, from what we've gathered, into these areas, whether it's dental, endodontic, periodontal, even iatrogenic, as you mentioned, through extractions and things like that, where you get a fistula. The key, however, is addressing the source. And you know, the quote that you wanted to kind of mention here is that if you, as an otolaryngologist and ENT, if all you see is all of you've known is the treatment with the, you know, with your antibiotics and your corticosteroids, then you're going to treat the case exactly that way and forget about some of these potential sources, which brings us to this little cartoon that you've designed, which I love, Michael, which I'm just going to let you talk about a little bit. It's an interaction here between an ENT and a patient in a flooded basement, right?
So yeah, the power of the cartoon, it kind of brings the point home nicely. You know, here you see the picture to the left. The ENT says, all right, we've tried conservative medical therapy and medical intervention. We've given you Flonase. Your sinus is still flooded with fluid. You still have postnasal drip. Let's move forward to a surgical intervention. Let's do a functional endoscopic surgery and widen out that drainage. And we're going to focus in on drainage to cure your problems. And you know, these sinus surgeries, they're a lot more expensive than a root canal. And so the patient has congestion, infection, postnasal drip, and oftentimes the ENT is not really equipped to diagnose the subtle signs of endodontic pathology that could actually be the source of it. And in the slide to the right, you see the endodontist saying, look, I know it wasn't consulted, but maybe shutting off this leaking tooth will be a more elegant and definitive solution to the problem rather than simply jumping straight to surgery. This is really, you know, there's just some good articles in the ENT literature supporting this cartoon. An article by Ferguson really supports that, and we can point a slide to a more academic lecture detailing all the literature that supports this. But
no, you're absolutely right. It goes back to the most fundamental thing in medicine is let's go back to the source and treat the source of the problem rather than the manifestations of the problem. It's the typical modern problem of giving drugs to patients to treat the side effects of other drugs. It's, you know, it's just not really understanding how things work in the biologically and not addressing the source here. So obviously this, I think this really highlights the problem as a whole, and is a great cartoon. And you've been kind enough to kind of show it to us, and I've mentioned that, you know, it could be shared with others as long as the credit is given to the originator here, Dr. Michael Lewis. But Michael, tell me also about what we can do as dentists, be it general dentists, as well as other specialists, in terms of raising awareness among our own profession, other than doing videos like this one that we're doing together.
Well, I think that first we have to recognize and take a critical look at ourselves, Alan. I don't think that we as a dental community are really adequately diagnosing these subtle signs of dental infection properly. Oftentimes, I see in my own relationships with general dentists, there tends to be a prevailing attitude of, oh, it's a quiet lesion, it's not really bothering the patient, let's just monitor or watch it. And the point that I want to drive home is that subtle signs of dental infection should not be dismissed. If a patient is complaining of slight tenderness to the tooth, it should be investigated thoroughly. And if there's subtle signs of palpation sensitivity, it should be investigated thoroughly. And appreciate the implications that these lesions can have upon the patient's general quality of life, and understand that they're not just quiet lesions. These are biologically active inflammatory lesions that should be addressed.
I think legally the term for that is supervised neglect, correct? Is when you see something, but you're like, well, you're not treating it.
I think there's a lack of appreciation within the dental literature of this thing. So I think this is relatively new stuff, and it's our job to kind of point it out and to say, hey, this warrants further investigation. I think there's a lot more work that needs to be done on this subject in terms of quantifying the incidence and really studying this area. It's a really ripe domain for dental researchers to study more fully. I think the SNOT survey is a wonderful, wonderful tool in terms of conducting more large-scale studies. I think there's room for collaboration between the AAE and the American Academy of Otolaryngology in terms of conducting more studies on the patient pool that presents to an ENT office. I think that it would be great, wonderful to do a double-blind study and in terms of outcomes when this patient is just treated strictly with by the tools that an ENT profession has to offer, and then comparing that to the satisfaction rates and the efficacy of first doing a dental screening before jumping to medical or surgical intervention. I think there's a lot to be done there. And I'm calling for people to kind of pick up this work and do it more in an academic setting.
Yeah, I agree 100%. There's a lot of need to raise awareness in that area and do more research to find out more about these interrelationship that's really significant. What about patients? What should patients know? I think obviously having them be aware that there is this interaction and that the sinusitis could be related to the tooth if you have dental problems is the beginning. Anything else that you want to add to that?
You know, it's this understanding that intimate relationship between the sinus and the tooth, and understanding the implications it might have on sleep patterns. That's what I see a lot. I see a lot of patients reporting that once the underlying sinus inflammation goes down a little bit, that they really report a more satisfying sleep pattern, and that's been something that's really profound and of value to the patient. And you know, patients need to be more aware that maxillary sinusitis, a lot of it is tooth related, and to be aware that seeking out a consultation with a cone beam CT equipped endodontic specialist could be of great value to them. And oftentimes, you know, they are really in a position to help in a fairly cost effective and just clinically effective manner.
Yeah, I agree. I think also it's important to understand that, as we mentioned previously, the importance of quality treatment, you know, in order to maximize the chance of success, diagnostics first as well as chance of success. Also, I would assume some kind of a collaboration and work together between the organizations, whether it's the American Association of Endodontists or the American Association of Laryngologists, would be helpful as well.
Absolutely. That's kind of one of the purposes that I'm kind of putting together this video. I think it's
a call to
really
action.
A call to action. I think that there's a lot of work to be done in this arena. I think there's a lot of collaboration that needs to occur between our two specialties. You know, traditionally ENTs work very closely with oral surgeons when they see a clearly bombed out tooth where the osseous lesion, it's an apical marginal defect, the entire tooth is bombed out, and there's an oral antrofistula. Oftentimes they work in close association with oral surgeons, but they oftentimes don't have much exposure to the endodontic specialty. And there's a relationship there that needs to be cultivated and nurtured and nourished. I think there's a lot of work that can be, a lot of good referral patterns that can really benefit the patient if they were to be nurtured and developed.
No, you're absolutely right. This requires a lot of collaboration together. So what about the insurance companies? They obviously have a role in terms of triaging care oftentimes. Is there anything that could be done on that front?
It's a good question. You know, it's interesting. Oftentimes insurance companies, before they will authorize going ahead and doing a functional endoscopic sinus surgery, they need to have documentation of at least attempts at conservative management, whether it's through Flonase or some type of more conservative approach. And oftentimes that will be tried as a first line management of the situation. And it'll be interesting to see, as more research comes to light, if insurance companies start to include referral to an endodontic specialist for clearance prior to moving forward with more aggressive intervention. You know, in my opinion, I think the idea, it should really be even before attempts at medical management. I think proper diagnostics should be done before prescription of antibiotics, because as I mentioned before, the use of antibiotics can oftentimes cloud the diagnostic ability of the treating physician. Now, there's so many times where I've seen a patient on antibiotics and it really makes the diagnosis more difficult. I would like to see dental diagnosis by the cone beam CT equipped endodontic specialists be a front line in terms of management of these things, rather than, all right, let's send to the dentist after everything else has failed. Again, more work needs to be done on this subject to validate that assertion. I don't have all the answers. I think this is a pretty, we're learning more and more about this stuff. I'm learning more and more about this stuff. I think more work needs to be done before I make a blanket prescription, but I do think that aggressive study of this area and kind of moving forward to a dialogue between our two umbrella organizations really makes a lot of sense.
Well, I agree, Michael. We're all learning on this, and you're doing your part in teaching all of us more about this topic, which has been really wonderful. I want to thank you so much for putting together this presentation. It was not only informative, it was enlightening. I think we're all now more aware of the important relationship between these closely related anatomical entities of teeth and the maxillary sinus, and how they could be potentially the source of the teeth being the source of the maxillary sinusitis, especially if you have somebody who has a unilateral sinusitis with a fluid-filled sinus that could really well be associated with a tooth problem, whether it's a viral tooth that has died and is now necrotic, or a previously treated tooth that has a persistent disease. So these are issues that have to be kept in mind. Again, the quality of treatment diagnostics and as well as the treatment is an important prognosticator of success and the resolution of these symptoms as well. So these things are very complex, and thank you again, Michael, for bringing this this topic to the surface, so for all of us to be enlightened and probably focus a little bit more about this very important topic. Dr. Michael Lewis, Director of Foundation Endodontics and faculty at Hackensack Medical Center and in private practice at Teaneck, New Jersey. Dr. Michael Lewis, thank you so much for joining me today.
Thanks for having me, Alan.
For Rivolvendo, I'm Ali Nisse, and I hope you found this information helpful.